Welcome back to Audioboards. Today we're diving into a high-yield scenario every internal medicine resident encounters on general wards, or in the CCU, new onset heart failure. We all know the standard floor pattern: dyspnea, swollen legs, order a chest x-ray, BNP, and an echo, and start a loop diuretic. But today, we're going to step beyond that routine order set and walk through bedside hemodynamics, modern biomarker nuance, the deep etiological hunt, advanced imaging, trial data, and rapid sequence 4-pillar GDMT initiation. When a patient arrives with acute dyspnea and volume overload, you want to split your brain into two parallel tracks right away: hemodynamic stabilization and diagnostic phenotyping. First, assess those hemodynamics at the bedside. Ask yourself, are they warm and wet, or cold and dry? And don't rely solely on pedal edema. The physical exam still reigns supreme when evaluating filling pressures. Look closely at the jugular venous pressure. An elevated JVP remains one of the most specific signs of increased left ventricular filling pressures. Listen for an S3 gallop, which signifies rapid passive filling into a non-compliant left ventricle in HFrEF, and palpate for a displaced sustained apical impulse. Now, when looking at initial lab work, we often reach for B-type natriuretic peptides like BNP or NT-proBNP. These carry a high negative predictive value, meaning a completely normal level in an untreated patient should make you look very hard for non-cardiac causes, like a pulmonary embolism or severe COPD. However, interpreting elevated levels requires real nuance. First, remember the obesity paradox. Obese patients frequently demonstrate falsely suppressed natriuretic peptide levels due to increased clearance and altered synthesis. Don't be fooled by a normal-ish BNP in a severely symptomatic patient with a high BMI. Second, keep in mind that renal dysfunction and atrial fibrillation both drive natriuretic peptide levels up independent of acute ventricular stretch. And third, consider ARNi therapy. If a patient is taking sacubitril/valsartan, sacubitril inhibits neprilysin, causing true BNP levels to artificially rise. So in patients on an ARNi, you must order NT-proBNP instead, which isn't cleared by neprilysin. Now, let's say the baseline echocardiogram comes back and reveals an LVEF of 30%, a clear new diagnosis of HFrEF. A major pitfall in training is stopping at the label non-ischemic cardiomyopathy. Non-ischemic isn't a true diagnosis, it's just an umbrella term. As a clinician, you want to structure your etiology search across 5 core buckets. First up is coronary artery disease. Ischemia accounts for 60 to 70% of HFrEF cases. A non-invasive evaluation like CT coronary angiography or stress imaging via CMR or PET is appropriate for low to intermediate risk profiles, whereas an invasive coronary angiogram, LHC, is indicated for high-risk patients, active angina, or refractory shock. Second, evaluate metabolic and endocrine drivers. Check a baseline TSH, HbA1c, and hepatic and renal panels. Crucially, obtain a complete iron panel including serum iron, ferritin, and transferrin saturation, TSAT. Iron deficiency defined as a TSAT under 20% or a ferritin under 100 nanograms per milliliter, or a ferritin between 100 and 299 nanograms per milliliter with a TSAT under 20%, is an independent predictor of adverse outcomes. Treatment with intravenous ferric carboxymaltose or ferric derisomaltose improves functional capacity and significantly reduces heart failure readmissions, completely independent of whether the patient has anemia. Third, look for infiltrative and storage diseases. Always maintain a high index of suspicion for cardiac amyloidosis, especially in patients presenting with hypertrophic phenotypes or preserved EF, low voltage on ECG relative to wall thickness, or a clinical history of bilateral carpal tunnel syndrome or spinal stenosis. For screening, order serum and urine protein electrophoresis with immunofixation SPEP/UPEP with IFIX, alongside serum free light chains SFLC to evaluate for AL amyloidosis. Once AL light chains are ruled out, you can order a pyrophosphate 99MT-CPYP bone scintigraphy scan to diagnose ATTR amyloidosis non-invasively by looking for grade 2 or 3 myocardial uptake. For other infiltrative conditions like sarcoidosis and hemochromatosis, screen for hemochromatosis via iron saturation and use cardiac MRI with late gadolinium enhancement to identify the patchy non-coronary LG, a characteristic of cardiac sarcoidosis. Fourth, investigate toxins and inflammatory processes. Take a detailed toxicology history covering alcohol, cocaine, amphetamines, and cardiotoxic oncologic therapies such as anthracyclines, trastuzumab, VEGF inhibitors, or immune checkpoint inhibitors, and suspect acute myocarditis in a young patient presenting post-viral with marked troponin elevation and clear coronaries. Fifth and finally, evaluate for tachycardia and genetic causes. Persistent rapid AFib or frequent PVCs, typically over a 10 to 15% burden on Holter monitoring, can induce reversible LV dysfunction. And lastly, a strong family history of premature sudden death or dilated cardiomyopathy warrants genetic testing for mutations in genes like TTN, LMNA, or PLN. As you refine this picture, you might wonder, when should you advocate for advanced imaging like a cardiac MRI or invasive hemodynamics with a right heart catheterization? Cardiac MRI is the absolute gold standard for tissue characterization, subendocardial or transmural. Late gadolinium enhancement follows a vascular territory pointing to an ischemic scar. On the other hand, mid-myocardial or epicardial LGE points to non-ischemic patterns like myocarditis, sarcoidosis, or dilated cardiomyopathy. T2 mapping helps detect active myocardial edema, while extracellular volume ECV mapping quantifies diffuse interstitial expansion or amyloid deposition. As for right heart catheterization, it isn't required for routine, uncomplicated decompensations. However, an RHC is vital when you're trying to differentiate HFpEF from non-cardiac dyspnea or primary pulmonary hypertension when managing cardiogenic shock or hypoperfusion states to accurately measure cardiac index and systemic vascular resistance, or when guiding tailorable diuretic strategies in refractory congestion using PCWP and CVP measurements. To close out, once HFrEF is confirmed, modern 2022 AHA/ACC/HFSA guidelines require the initiation of 4-pillar guideline-directed medical therapy. The outdated approach of starting one drug and slowly titrating it over several months before adding the second has been completely replaced. Current practice emphasizes rapid, simultaneous, or near simultaneous initiation of all 4 classes at low starter doses during the index hospitalization, followed by aggressive outpatient titration. Those 4 pillars are an ARNi, sacubitril/valsartan. This is preferred over an ACE inhibitor or ARB as a class 1 recommendation. Just remember that if you're switching a patient from an ACE inhibitor, you must enforce a strict 36-hour washout period to avoid angioedema. Evidence-based beta blockers, specifically carvedilol, metoprolol succinate, or bisoprolol, initiate these once the patient is euvolemic, hemodynamically stable, and off intravenous inotropes. Mineralocorticoid receptor antagonists such as spironolactone or eplerenone. Keep a close eye on potassium and EGFR, holding therapy if potassium exceeds 5.0 milliequivalents per liter, or EGFR drops below 30 milliliters per minute per 1.73 square meters. SGLT2 inhibitors. Dapagliflozin or empagliflozin SGLT2 inhibitors can be started immediately regardless of baseline glycemic status or diabetes history, offering early hemodynamic benefits and renal protection down to an EGFR of 20 milliliters per minute per 1.73 square meters. So to summarize the core approach when evaluating new onset heart failure, decongest early, hunt relentlessly for the root etiology using targeted screening and advanced imaging, evaluate and treat iron deficiency prior to discharge to prevent readmissions, and establish all 4 GDMT pillars before the patient leaves the hospital. Thanks for listening to Audioboards. Stay tuned for more educational content in our next episode. The views and opinions expressed on the Audioboards podcast do not necessarily reflect those of our employers. This podcast is for educational purposes only and should not be used to diagnose or treat any medical conditions. It is not a substitute for professional medical advice. Always consult a qualified, board-certified healthcare provider for any medical concern.